Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Lana Gurvich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Welcome back, Turd Nerds.
Hey, Turds.
I would like to say that today we are short a turd because she happens to be on a big cross-continental vacation. She will be back in a couple of episodes, but we would have replaced her with the famous Mark Davis.
Just temporarily, but we are very excited about this turd replacement.
Me too.
So Dr. Mark
That's
Davis.
actually, wait, a turd replacement.
Ooh, that's
Did
like
I just
FMT.
do an intro to what we're talking about?
So,
I
because
think that was
Dr.
an
Sand blew it up,
Sorry.
we are doing a full picking Dr. Davis's brain on FMT. Let me introduce you to Dr. Davis first to understand why we're going to pick his brain on FMT. The first year I ever heard about FMT was that conference. Was it 2013?
Can you spell out FMT for
Fecal Microbiota Transplant.
There we go.
What was the first lecture you ever gave on fecal microbiota transplant?
It was in January of 2012 at the very first NUNM gastro conference.
So I
ever.
had known Mark Davis. We were kind of in the same community, but he was a little baby doc and I was like a middle-aged doc at that point. And he came up and he did this incredible presentation explaining fecal microbiota transplants. Basically, what was so incredible about listening to Mark talk was he brought it all the way back to classical Chinese medicine. So that's 1300s. But also he cited all of the studies that were coming out on this new intervention, FMT, and he was completely able to tease it apart and pick it apart. And that is how I describe Mark Davis. He straddles the world of intensive scientific rigor and anecdotal, millennial studied, millennial practice medicine. It is a beautiful thing for us to straddle.
Not millennial generation, but
not
like 4
millennial.
millennia.
Yeah,
But also, it benefits millennials.
That's true.
Big time.
We have asked Dr. Davis to come in first to talk about fecal microbiota transplants.
And Mark Davis is a naturopathic doctor based in...
I'm in Maryland, but I do all telemedicine. So it's Maryland, DC, Oregon, and California.
Amazing. So based sort of everywhere.
Mark also was the one who convinced me to have multiple licenses.
Hey.
That was also Dr. Davis.
Naturopaths supporting naturopaths.
Okay, so if you are ever Googling FMT, Mark Davis is going to be the first name that comes up. Can you, up there. He's going to be up there in some of the first names.
I think that tells a little bit about your Google searches.
Yeah. Can you first explain what is FMT, the history of it?
Okay. Yeah. 1700 years ago,
to the day.
The Handy Guidebook for Emergencies is the name of the Chinese book by Ge Heng. 1700 years ago, they talked about using an oral infusion of poop soup from a healthy donor in cases of emergencies, like febrile diarrhea, crazy stuff going on.
It's like a last-ditch effort.
Last-ditch. Like the herbs don't work, the needles don't work, the diet isn't working.
Kind of how they did,
where they're going to die.
Like bleeding therapy. Like this person's on their way out.
Probably later, though.
Try.
Probably bleeding therapy has been ruled out already before you're going to.
I'm sure. Because it's so extreme.
Yeah.
And so that's the oldest record. And then we have it in the 1500s in Europe. This guy, Christian Franz Paulini, wrote about it. It's in the old Korean literature. And so it's popping up here and there. And then the way it came into modern times, I don't know if I've told this story very often, actually.
You heard it here first, Turds.
So it was University of Colorado. And there was basically a lot of C. diff colitis happening, but they didn't know it was C. diff. Like we'd identified C. diff as a bacterium, but we didn't know that it caused bad diarrheal disease. So there's bad diarrheal disease. People were dying, especially elderly people. And these doctors were like, in Colorado, were like, what are we going to do? We can't figure anything out. And this one nurse working on the case went and talked to her neighbor. She's like, oh my God, all these patients in my ward are dying. And the neighbor was like an immigrant from China and was like, well, there's this thing we do in emergencies. Like, it doesn't get done very often. If they're about to die anyway, you should give them poop soup. And so the nurse went back to rounds and told these doctors and said, oh, there's this poop soup thing. And they were like, we can't give them poop soup. Let's put poop up their butt. And this was the 1950s, so there was no IRB, there were no standards of how to do a clinical trial. So there was no screening. The doctors were just like, are you healthy? And she was like, sure. And she's like, okay, collect some of your poop, and Dr. So-and-so is pretty healthy, and then make an enema and give it to the patients, but don't tell them what it is.
Oh my goodness. So no informed consent.
No
I was about to say questionable
was not a thing in the 1950s.
Wow.
Yeah. So they reported these 4 cases of people who were pretty much definitely going to die, and they all completely reversed all their symptoms and got better. And so that's the first report in modern
up
times.
the back end.
Just up the back end.
And just an enema, not a colonoscopy,
Totally.
just an enema. And then nobody talked about it for like a couple of decades?
For a couple of decades until the 80s. Then we had a rash of reports. There was...
How they just let that one go?
That's medicine, dude.
Yeah.
Medicine is discovering something and then forgetting it for something cooler and then rediscovering it again. That is literally medicine.
Okay, so the first report in like the peer-reviewed literature then is, there's 2 reports both in 1989. But let me say this. Naturopaths have been doing it in the United States since at least 1982.
Yeah.
Since before that later report, and I don't know where. So Carroll, OG Carroll was doing it, and he dropped out of a heart attack, and then Pam Snyder bought his practice, and she found out he was doing it. Anyway, so in 1989, there's a case report of a guy with ulcerative colitis who reverses his own ulcerative colitis. He was a medical doctor, and he was like, look, I did this thing. And then Tom Brody in Australia publishes a case series of like 50 people with IBS and IBD, and their responses are amazing.
So not even necessarily infectious.
No, none of them. Nope. Yep. The 80s, the early 80s, the first 80s reports.
So the early things were infectious, and then it went to inflammatory conditions.
Yep. And
how did it pick up traction for C. diff? How did that happen?
Well, so it was C. diff in the 50s, and
there's no treatment.
Yeah.
So
yeah. That's a good question. I actually don't know who the first more modern C. diff trial was, but when I started doing it, there were like half a dozen docs doing it in the United States.
And you started doing it with C. diff or with UC, with ulcerative colitis?
With UC. So I read Tom Barodi's reports from 1989. Yeah. I literally remember where I was standing in the hallway at NCNM because I was like, this is going to change my life. This study that I just read. I'm so obsessed. Immediately. I went back and told all my friends, and they were like, wow, you're obsessed.
First sight.
Okay, so you stumbled upon Tom Brody's work.
Yeah.
And then you said...
I said, I have to do this.
Yeah.
I want to reverse ulcerative colitis in everybody. Turns out it's more complicated than that. It doesn't work for everybody. But
I do have a couple of people, though, that it was life-changing. And then I have plenty of people that it's a wah-wah.
Yeah, plenty of those.
But it's like, compared to so many of the other treatments for these things, it's gross and it has risks, but so does everything.
Well, yeah, the risks are pretty low compared to other things. Like I would say actually the amount of people that get put into clinical remission from FMT is about the same as the best biologics and small molecules.
Yeah, not to mention like colonic resection.
But I'm like, that's not that good. Because biologics and small molecules, those are not
they're not that good.
Yeah.
But that's FMT. I'm obsessed with it. I've done it thousands of times now, but it's not the be all end all. Like I love how naturopathic it is. UC. Yeah. Well, it kind of is the be all end all for C. diff.
It is the be all end all for C. diff. That
Silver
is correct,
bullet.
Right?
Amazing. 90% plus. There's this doctor, infectious disease doctor in Canada, Christine Lee, who's published a lot, came to my practice in Portland one time, and we were chatting, and she was like, I actually think it's basically 100% for C. diff, unless there's some massive obstacle to cure, like I've had people not get cured because of big colorectal tumors or because they actually had IBD also.
Something else.
Something else.
That makes sense.
Yeah.
So if you don't if 5 FMT enemas don't cure your antibiotic resistant C. diff, there's something else going on.
It's crazy.
Okay. So FMT. Okay. And then let me back up. How many? So here's what I'd like you to cover. This is where my brain is going.
Okay.
1, can you differentiate rectal administration versus oral?
Yeah.
That's the first thing.
Okay.
2, can you discuss number of treatments needed?
Yeah.
And 3, can you discuss remission rates? Or no, sorry, not remission rates. Can you like getting reinfected?
For C. diff?
Yeah, for C. diff, like after treatment.
Okay. Vancomycin to just talk about C. diff at first.
Okay.
Niacin, I think cures around 65%
Yep.
of people.
Which is the standard of care.
That's the standard of care.
That's the
and
antibiotic
oral
that we give.
vancomycin is like a pretty safe drug.
Yeah,
I don't mind giving
that
that
I
at
don't
all.
mind that antibiotic.
Yeah. And then it has like a 10-20% relapse rate or something like that.
Is that one course of vancomycin?
That's
'Cause a
one
lot
course of
people,
vancomycin.
Okay.
So 10 days.
Yeah,
Yeah.
10 days. And then,
Difficile?
well, then usually often you give a second course. I mean, it depends on who you are.
Yeah.
So I'll give FMT right away after that.
Right.
Actually, at this point, I give FMT as first line. I don't even have to give any antibiotics first. Yeah.
Okay.
Some people do need it.
Yeah.
But some people respond very well just to no antibiotics at all.
Okay. And so then one treatment?
And then difficile has better outcomes at a lower relapse rate.
Slightly better.
Yeah, slightly better.
Yeah.
It's just more narrow, more
Yeah.
specific just for C. It causes a little bit less dysbiosis. And then FMT is like 85 or 90%.
So why don't you start there?
I do.
He does, but
okay.
a standard of care does not.
Standard
So
of care
sometimes
does
patients will come to you having already been on an antibiotic course.
almost
and
all
then-
the time.
Yeah.
Didn't work. That's why they're with you.
Seeking out me.
Yep.
Yeah.
Occasionally I have patients who are like, oh, it's C. diff and I'm just not recovering. And so I'm like, okay, I got the thing for you.
Yeah.
So 85, 90% remission rate. And then it depends a little bit, like maybe 5-10% relapse rate, and all the way up to 0 relapse rate in some studies.
Okay. And then my next question is oral, rectal, colonoscopy guided, which ones?
So they're all within the same ballpark.
Okay.
I think colonoscopy is slightly the best, and enemas are like right behind it. It's like 90 and 87, and then
then
capsules
oral.
are like 82 or something.
Oh.
It's like they're close.
So do you give people a choice?
Yes. So when I'm working with people, there's a lot of things like, are they making it themselves? Are they getting it from a bank?
Right.
What's their healthcare budget like? Are they willing to do a rectal therapy? For some people, there's a lot of emotion or discomfort they want to avoid around that.
Yeah.
Some people, the idea of swallowing poop caps is like real gross.
And it's a lot of caps, right?
Yeah, for C. diff, I give 35 caps on day 1
Okay.
and 35 caps on day 2.
And it's a
Wow.
2-day treatment.
So here's the
That makes all my treatment plans so
Yeah.
easy peasy.
But it's 2 days.
I'm not taking complaints anymore.
but it's not like for a month or whatever.
Right,
It's like
right,
35
right.
caps. Like they sit there in my office and they go boop, 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 boop.
Yeah.
I would say actually 35 caps on one day
Uh-huh.
probably has about an 80% cure rate. And if you
Okay.
do it 2 days in a row, it's like 90.
Are you having them do a prep like they would do a colonoscopy?
No,
You're not. Okay.
no. I have them fast for at least 4 hours beforehand
Okay.
and wait an hour afterwards for the
Not bad.
capsules.
That's not bad.
But they're not doing any kind
Yeah.
of peg, clean out, anything like
Do
that.
people ever get sick? Barf.
Yeah. So I've done, like I said, given thousands of courses
Yep.
now, probably a little over 2,000. And so I've had one guy
Wow.
Yeah.
who midway through taking the caps puked up a few.
And you think it's
Because he just thought, oh my God, I'm eating poop capsules.
I don't know.
It's a pretty good track record,
I
all
don't-
things considered.
yeah, that's pretty good. And so, he was taking his first bottle of
Yeah.
35 and he was like 15 or 20 in. And I was like, come back and do the rest of these tomorrow.
Yeah.
Cured of C. diff. It was good.
Wow.
I just want to paint pictures because I feel like our audience might not understand how debilitating C. diff
Yeah.
is. It is, you have fecal accidents, fecal emergencies, Bristol 7 water coming out of your butt nonstop. You can't control
10,
it.
20, 30, 40 bowel
Yeah,
movements a day
plus,
sometimes.
Not to
And-
mention the fatigue and
No,
weight
but
loss.
not to
and-
mention that it could
brain
land you in
fog.
the hospital because you cannot form a stool, so you're losing all of your fluids.
Especially elderly people. Renal
Yeah.
failure
Yeah.
is a big.
So, I mean, it's like to do 35 capsules of stool, it's better than you sitting and having bowel accidents. Like
and they're
bowel
triple
accidents.
encapsulated. It's not like, you're shoving poop in your
Yeah.
mouth. It's like yeah. So we take the stool from the screen donor and we blend it with normal saline and we filter it and then we centrifuge it and we
Huh.
take the product and we centrifuge it again at a higher speed and then we get this
Pellet.
pellet. Yeah. And we pipette that into number 1 size caps that are very tiny. We slide those into 0 or aught size caps and slide those into double aught caps. And that's what we put in the medical freezer and that's what people take. So
And
they're frozen. when
they're
they take
frozen
it.
when they
Yeah,
take
that
them.
helps.
it's so interesting. Okay, so your preference is depending on patient tolerance.
Yeah, it's like, because to me, it's like 80%, 90%. That's the
Yeah.
same ballpark. There's
Yeah.
a lot about what the patient prefers.
Do you have a protocol where you're, after they take the FMT, where you're hoping to support their future microbiome?
Yeah. It's a low confidence protocol, but it's what so I tell people probably avoid things that inflame you for a few months. And probably that's alcohol. And for a lot of people, that's gluten and dairy. Yeah, thing that's like junk.
Yeah.
Anything that inflames. If you have a thing specifically for you that inflames
yeah.
you, it's nightshades or whatever. Avoid that for a few months. Try to avoid antibiotics. Some people can do antibiotics and it's fine. Their new microbiome stays robust.
Cool.
Other people will relapse.
Do you do like probiotics or prebiotics?
I don't give probiotics, but I do give apple pectin.
Cool.
Sometimes that's in the literature. There's one UC study that showed better engraftment and better results. And there was another constipation study that showed better engraftment and longer results.
And before you give the caps, right after?
Right after.
Right after. For like weeks and weeks.
Yeah, for weeks.
Like a couple of grams of apple pectin.
So actually 20 grams, but one was 20 and one was 8 BID, so 16.
So I would imagine these people have like rapid transit on average. Do you do anything to kind of slow down the transit to hold the...
Well, so yes. So sometimes that's a reason to use caps instead of enemas because it's fine with the caps. They can have as rapid transit as they want. But with enemas, sometimes they can't hold in 4 ounces for 4 hours, which is what I consider a full dose. And so that can be a problem. Sometimes when I used to prepare them fresh, now they're all frozen, but when I would prepare them fresh, I'd mix some ground psyllium in with it before I administered it, and that would make it a lot easier. And then I'll give loperamide, 4 milligrams of loperamide.
Okay, so I'm doing mental math in my head, and I'm like, 4 ounces, that's like 120 mils. How easy is it for patients to retain that?
It's not that hard. For like 90% of people, they can just go about and have their day and walk around and whatever. And I tell people usually on the first day, like make it a weekend when it's chill. You don't have to do anything because 1 out of 10 people like really has to lie there in order to retain that amount, especially if they have a lot of bowel frequency. But for most people, like I had a guy swimming laps while retaining another guy at a yoga class one time, I remember. So it's fine for most people.
Impressive.
And then that is true because I would think that somebody with like UC would have a harder time retaining because they're more inflamed. The tissue is more raw, more friable. Do you see that?
Yes. So I am thinking of a woman I treated who was in a severe ulcerative colitis, flare of pancolitis, and she was having like 30 or more bowel movements a day. And the first enema I gave her, 120 mils, she retained that for like 15 minutes. That was all she could do because she had so much inflammation and urgency. Yeah. By the end of 10, she was great. And it doesn't work for everybody, but she's in that great group of people that work.
So C. diff, 1 to 2 doses.
1 or 2. Yeah. I tell people for enemas up to 5.
Okay.
And that's probably overkill. Like 1 or 2 often does it, 3 usually, 4, 5 always, or it's some other cause.
And then UC?
UC, it's a minimum of 10.
Okay.
to know if it is starting to help.
Oh, so it can be a big thing.
And sometimes it's way sooner. Some people start to notice a difference in the very first one. But I tell people if you haven't seen a difference by 10, then you're not going to see a difference.
So are you parsing like all the other stuff we would do for UC, all the other wonderful naturopathic stuff? Are you parsing apart that with these treatments so you can tell if it's working? Do you kind of
It really depends on the person, their severity, their preferences, like all kinds of things. Like I mix things up all the time and it's hard to tell what's working. Where I'm like, you start this diet and do this herb and do some fecal transplants and we're just trying to get you.
And are you going on symptoms or do you do like a calprotectin?
Symptoms, calprotectin, CRP.
Okay. And how long after an enema or any FMT would you wait to do a calprotectin?
Well, calprotectin, I think of it as the hemoglobin A1C of gut inflammation, colon inflammation a little bit. So it shows like a longer term of inflammation because it's a neutrophil breakdown product. So it takes a while to change. I say it takes a while to change, but then sometimes you see things different the next day.
After ozone.
Yeah.
Yeah, I 1 week. 1 week after direct intervention, I will look at
And I think calprotectin also just naturally fluctuates a little bit. So,
but if someone's like 1,500 or something from proctitis.
Proctitis is kind of the worst.
Proctitis is weird and hard to treat.
But that's also where you're going to get that enema directly.
Yeah. So and my other question, actually just building on that is, so if somebody has distal colitis versus pancolitis, is FMT going to be a better intervention? Does it work for pancolitis?
It works for pancolitis. I don't think it's better for proctitis, weirdly. Like maybe for the subset of people it works for, you need fewer, but it's not like a higher percentage of people are going to respond.
Because it's not just a topical treatment. It's like a system treatment.
Yeah. I mean, it is topical, but it's alive. And so it can grow into your ecosystem. I have a story I've told at a lot of conferences of a young woman who came to see me with Crohn's colitis. And she was probably 20. She had to leave the university on medical leave of absence. She was, I'm going to say 5'4" and like 90 pounds probably. And, and her, she was not responding to anything, including steroids. And her gastro team said, all we can do is suggest to cut out your colon, but you don't weigh enough. So surgery isn't safe. So we're just like scared for your life. And I was like, oh my God, I am too. Yeah. And her dad and her brother came to the appointment with her, so sweet. And we're just like, we want to do anything for her.
I
Could this
hope this
help?
has a happy ending.
It does. It does. So at that time, I told everybody, do 10. If you don't see benefit by 10, then you're not going to get benefit. And she did 10. I actually went to that family's home. They had a setup in their garage. The dad was like, I just want to make sure I'm doing everything right after I had screened a donor for them. And anyway, so she came back in and she hadn't gained weight. She was pooping just as much. Her pain was just as bad. It was horrible. But sort of coincidentally, she had endoscopy, lower endoscopy, colonoscopy scheduled at around that time. And the endoscopist was like, oh my God, whatever you're doing, keep it up. Because there's profound healing in the distal third of your colon, but so much friability inflammation in the proximal 2/3 that we're not surprised you don't feel better. And so she did 30 before she started doing it. And then kept going till 50, and she felt all the way better. She went into complete clinical remission, went back to school, got a job at NCNM after that because she was so into naturopathic medicine.
Yeah. Okay. So let me just recap. We've talked about C. diff, almost curative. We've talked about ulcer colitis, maybe Crohn's colitis. When you presented at the Gastro EMP, by the way, guys, it was the most intense. Mark is excessively entertaining to listen to. I have never heard that man talk so fast. He talked faster than me to get through all of the data on MMT.
It was such a talk.
So can you give a, when else should we think about it? Yeah.
So you were talking about what dosing is important for what conditions.
Yes.
I have to talk about the liver.
Okay.
So there was recently a dose ranging trial for hepatic encephalopathy. And here's what they found. Every dose tested in any trial reverses it about equally, including as low as 10 caps taken once, or 1 enema.
Okay, reverses hepatic encephalopathy.
That's amazing.
So
you should see the trials.
So the brain is less swollen, or the liver is healthier, becomes healthier.
Both. So the mechanism of action of hepatic encephalopathy is your liver is very inflamed and you have a dysbiotic microbiome. The standard of care is rifaximin and lactulose. So it's very microbiome oriented.
Yeah.
And so the dysbiotic microbiome is putting out a bunch of toxins, especially ammonia, and the liver can't filter that ammonia out, gets into the blood, goes through the blood-brain barrier and causes mood changes, insomnia, irritability, seizures, coma, death. And so when you change the microbiome, you are able to reverse it like 90 to 100% of the time.
Probably more effectively detox everything out of the system.
Well, yeah, absolutely. Like it just gives the liver a break of having to deal with all of those toxins. And then the brain gets a break from all those toxins that the liver doesn't have to filter out anymore. And basically every dose works. So I have never treated it also. God, this is crazy. For severe alcoholic hepatitis has a high mortality rate. It's like a 60% 3-month mortality rate. But if you give FMT, it's like, at 60% 3-month mortality rate, it goes down to 30%. Drops it in half. In half.
So what does rifaximin and lactulose do?
In terms of for severe hepatic that's not my patient population. So lactulose and rifaximin is for hepatic encephalopathy. Is that standard of care for severe alcoholic hepatitis? I don't even know.
I'm fairly sure lactulose is. I don't know about the antibiotic.
Yeah.
Okay, so now I think for me as a naturopath, I can completely understand the liver connection with the GI. They're basically the same organ, but a little bit, they live in different neighborhoods. What else?
Well, let me just say one other thing about alcoholism and the liver. People who are alcoholic and can't stop drinking, you give them FMT and they crave alcohol less.
Wow.
You can actually take alcoholics poop and give it to mice. And the mice start choosing alcohol over water. And then you give the alcoholic person FMT, they crave alcohol less, and you give their new poop to the mice and the mice crave alcohol less.
That's wild. I wonder what the yeast population's like.
That is what I wonder too.
I wonder too.
My big question is celiac.
Yeah.
Because so many people have done a lot of damage, like architectural damage to their intestines with celiac and exposure to gluten. And it can take over 7 years to heal the gut from that, even if you're completely gluten-free, even if you're doing glutamine and all these other things. Is there any role of FMT in terms of...
Not that I know of. I have given FMT to people with celiac, but only because they have other pathology going on, and I'm just making sure their donor has a gluten-free diet.
Why is that so hard to heal?
It's a great question.
Okay, how about neurological diseases? I remember you talking about them. I remember it being mixed.
So there's like 15 or 20 cases of MS, and they're all like case reports. There's no like randomized controlled trials or anything, but it's all favorable. all of
Okay.
the 15 case reports are
Wow.
like, oh, looks like there's improvement, and those improvements seem to be durable, which blows me away. There are a few case reports for Parkinson's, for ALS. Unfortunately, I've been peripherally involved with half a dozen cases of ALS. They were all very advanced, and none of them saw any
Yeah.
improvement. And that's so such
What
a
about, I thought I
tragic.
was at DDW years ago and they had presented some maybe preliminary data on schizophrenia.
I don't know that. I don't know the
Okay.
schizophrenia data. There's 2 case reports of bipolar.
Okay.
There's 2 or 3 or 4 case reports of dementia.
Wow. That would be huge.
Yeah, but it's case reports.
Totally.
So,
I know. Yeah.
Any other conditions that this should be in our view?
I have a question.
Okay.
yeah.
Any thoughts on endometriosis?
Oh,
Because of that microbiome link. Like we can actually reverse endometriosis in mouse models with antibiotics.
Well, we could do it with FMT2 in mouse models.
Cool.
I
That's
don't think there
exciting.
have been human trials. Like
Totally.
there is a different gut microbiome in endometriosis, but there's never been a human trial, and I haven't worked
Do
with
you
it.
have thoughts on why or what that's doing?
No.
I mean, we can speculate the
Yeah.
inflammation and,
Yeah.
all the cytokine drivers for inflammatory signaling, but I don't know.
I think when in doubt for any condition, you just say it's the microbiome.
It for sure is, but yeah, it's just we need help in that realm too.
There actually are 2 case reports for
Uh-huh.
ALS of people who were unable to walk or breathe on their own and
Wow.
who actually got off of respirators and became ambulatory again. But they're case reports. And when there was a clinical trial that showed no difference from placebo, nobody was getting better. So I don't know what to
it's such
say.
a complicated neurological conditions. I wonder if the intervention would work better if it was detected earlier. Like they talk about with Parkinson's in particular, they're now training dogs to detect Parkinsonian symptoms or Parkinsonian disease like a decade before symptoms onset.
Right.
Yeah.
I'm curious if it's possible to do an intervention earlier, but I think when you're progressed,
Yeah.
it's really hard to turn back
Yeah.
time.
Yeah. I know we're getting towards the end of our time,
Yes.
but neurologically, there have been a few trials for autism spectrum,
Cool.
kids and
Yeah,
adults
they presented
with
that
gastro
too.
problems,
Yeah.
which, it looks like there are statistically significant benefits that are clinically meaningful
Cool.
that get better over time. There's the depression, major depressive disorder
Yeah.
literature is very intriguing.
Yeah,
I haven't
cool.
used it for that condition. And there are a ton of oncology indications,
Oh, right.
which is to
Oh.
say, for a lot of people, PD-1 inhibitors, checkpoint
Mhm.
inhibitors, do not work for their cancer. They only work for a small subset. And you give fecal transplant either from previous responders or sometimes just from healthy donors. And then all of a sudden you get a lot higher response rates to these checkpoint inhibitors.
So my takeaway here is do FMT. You got a problem, do FMT. Maybe we should have some conversation about safety or like the indications we're currently using it for, but it sounds like there's a lot of promise.
There's a ton of promise.
Yeah.
And I use it all the time. And I always tell people one of my big jobs as your doctor is to help you weigh the risk benefit
Yep,
ratio.
yep.
And maybe you won't benefit. Maybe you get a home run, but the risk is low.
Right.
There is one death associated with FMT, which was a clinical trial. FMT has been shown to, in some cases, reverse graft versus host disease. And so they were doing a clinical trial to
Wild.
see if it could prevent graft versus host disease. And so this was a man in his 70s with blood cancer in the middle of a bone marrow transplant who got FMT. And what he got was a drug resistance gene. And that did not harm him by itself, but he got, I believe it was a pneumonia unrelated to getting FMT.
Mhm.
He got a pneumonia. And because of horizontal gene transfer, it got that drug resistance gene from his FMT donor. And he was non-responsive
Wild
and he
stuff.
died.
That's
He maybe
crazy.
would have
But
died anyway,
it
but
is
he
a
died.
live human product, and so
Right.
there is more risk
It's
like
so
that.
complex. It's
Yes.
so complex. That's why we're all like, I don't know
Yeah,
what it's
I
doing
think my
fully, but
takeaway is C. diff is a no-brainer. Like
Yep.
and especially like I had a patient come in and she was in her 20s and she had 3 rounds of C. diff. And there is a couple of you can find docs, but there also are a couple of drug products that are now FMT
Yeah,
drug
there's
products.
Voust, which are just the
Capsules, yep.
spores of capsules, and then there's Rebiota, which is just enemas.
So her insurance said we won't cover it because she hasn't had 3 in a year, which is ridiculous.
Oh.
Because every time you get FMT, the likelihood of you, every time you get C. diff, the likelihood of you developing another C. diff is exponentially higher.
Right.
So C. diff is a no-brainer. UC is generally on my list. You know what I
Same.
mean?
And Crohn's colitis,
Yep.
Crohn's ileitis.
I don't think it's not on my list so much for IBS. You know, we have
Me
other
either.
We have
treatments
so
for
many
that.
things.
It does help sometimes. I've
Right.
got some great stories, but I've got a ton of failures
Right.
of
Well,
FMT
what
not
about
helping.
like the visceral hypersensitivity aspect of IBS? Because I think that's the hardest. We can get people pooping, we can slow down the poop, but the pain
Yeah.
from that or diverticulitis actually.
So the cases where I see it help is people who have a lot of food sensitivity.
Yeah.
Sometimes then they are tolerant, sometimes not at all. It doesn't always
Yeah.
work for those
Cool.
people at
Yeah.
all. But I've seen some great cases of that. And then some just like I had a ton of antibiotics at one point and I've had diarrhea since then.
Totally.
It can
Yep.
be a reset.
Yes, I
in
would
those
agree with that.
cases.
Okay, Mark, where can people find you? You are very proliferative. You have a course out. Where can people find you?
Okay, so foundational-medicine.com. That's my telemedicine practice. I have
We'll
a couple
link
of
it. We'll link
colleagues
it for you
there.
guys.
Thank
Yep.
you. Yeah, and so we have a course for people with IBD. It's 9 modules in about 12 hours. And honestly, more practitioners. We aimed it at patients, but we're really nerdy. And it's got hundreds and hundreds of references to the literature. So more practitioners have ended up buying it than patients. But
Cool.
it's open to patients and practitioners, and it's the cost of one visit with us. So.
And
That's
just
amazing.
to confirm,
Yeah.
because I also know you happen to have 6 websites. The only website people should go to is what?
Foundational-medicine.com.
Okay.
But if you want to access my FMT bank, also, that's probioticinfusions.com.
Got it.
Yeah.
It's no longer
Cool.
Dr. Mark Davis.
No. Well, I
Okay.
mean, that's up to.
Okay.
You can visit.
Amazing.
Thank you so much. We are going to have you back to
you.
talk about other bugs.
I would love to.
Other bugs in other places.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.